Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, and totally free for anybody who hasn't checked it out yet. Derms on Drugs is where cutting-edge derm meets hit-or-miss comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies Laura Ferris and Tim Patton to use our 60 years of combined derm experience to debate, discuss, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of dermatology, and it'll be the most fun you've ever had while actually learning something useful. New episodes drop every Friday, so join us on Scholars in Medicine, Apple Podcasts, Spotify, or whatever your preferred platform is. Well, folks, I got to tell you, I'm so excited this week. So CTCL has long been one of my favorite topics to talk about and think about, but least favorite things to actually take care of. And we've got a great guest on this week from Memorial Sloan Kettering, Dr. Shamir Geller, to really talk to us about some fascinating work he's done with dupilumab and CTCL, as well as talk about CTCL in general. So we are just going to go ahead and jump right into it with Dr. Patton here on our taping today on St. Patrick's Day. So Dr. Patton's got his appropriate garb on, and we will let him get us started.
All right. My deep dive was titled Integrative Epidemiology and Immunotranscriptomics Uncover a Risk and Potential Mechanism for Cutaneous Lymphoma, Unmasking or Progression with Dupilumab Therapy. This was by Cabrera Perez in the November 2024 issue of Journal of Allergy and Clinical Immunology. So first, the epidemiology. The authors went through the FDA Adverse Event Reporting System, the FAERS database from 2017 to 2023, mainly looking for reports of CTCL and mycosis fungoides with Dupi use, but they looked at other drugs and other side effects, to see if the signals were legitimate. They did some.
Pat, I'm going to jump in right there because I have the FAERS. Sorry, but the FAERS database.
Yeah.
So, Dr. Geller, you've done some work. You've published some stuff from the FAERS database, correct?
Yes, I
So is it like patients, doctors, anybody just calling in and being like, hey, I was on this drug and my left eye was itchy for 2 days, and that gets entered. Like, how does stuff get in there? How good of a database do you think of it as being?
So there's a lot of reporting bias. I mean, who gets to report there is mainly physicians and the pharmaceutical companies that run trials and other investigations into these drugs. So it's for sure it doesn't describe the incidence or prevalence of the diseases. And also the disease diagnosis, they do not have to report like how the diagnosis was made. Was it made by a pathology or clinical only? So it can be very, very unclear, the diagnosis sometimes that require some hypothesis. But again, it's large numbers, specifically when you deal with these zebras, like CTCL goes into that category. So it's easier to look into like big numbers when you go into this big registries.
Yeah. Right, because it was like they wanted a negative control, and so they picked hand and wrist fracture, right? That would be like, that is not associated, or there's no cause and effect with Dupi. But why would anyone, why is there one case of that in there? Who called them up and said, this guy broke his wrist, I'm going to put that in with Dupi? I mean, it's weird.
Or I'm going to put it in with any drug. Like,
right.
Is it maybe gabapentin, like you fell?
You fell, sure.
Broke your wrist?
Yeah, but if the patient fell while he was on the clinical trial using Dupi, then they have to report it.
It's reported.
We'll end up there. So it's most likely these are the cases.
So what percentage of it, do they have those numbers? What percentage of it is like from the clinical trial, the reporting there, and what percentage of it is, if a person comes in, you can fill out the forms, and do they have any data on that?
Wait, I got to jump in because that is the worst. Whenever like the nurses call them from the drug company, blah blah blah. You ready for your refill? Or have you been you've had the sniffles, and then I get a 9-page packet of just throw it away.
But nobody fills those out, right? If we think they're like, if somebody said, oh, the nurse from, Regeneron called and said, they broke their wrist, you just don't fill it out.
On air, I fill those all out.
Okay. Guys, stop.
All right. So,
even more
they
complicated.
looked at a bunch of
wait, Dr. Geller, what was that?
Yeah.
I say it gets even more complicated because some of these cases, they report all of the patient's medication at the time of the incidence. So you end up with like 20 or 30 medications and now figure out which one was responsible for this fracture or for the CTCL he presented with. So when we studied like the forest, we did two analyses. One's based on like a polytherapy or poly medication, taking anyone who just had Dupi as associated with the CTCL, and the others were only the reports of like a monotherapy, saying that it was Dupi causing CTCL, and it showed similar increased risk for CTCL in Dupi patients. So.
Okay. All right, Patton,
well,
go ahead.
We digress. Dr. Patton.
Yes,
Go ahead.
No
Back to your paper.
worries.
We were regressing, not digressing.
Yeah. It's always good to interrupt me, to be quite honest. All right. So they looked at different measures, proportional reporting ratios, reporting odds ratios, confidence intervals, Bayesian something. I liked AE score the best. So the AE score, it accounted for limitations inherent in the PRR and ROR by assigning higher weights to events that occur often with the drug of interest and that are disproportionately associated with the query drug. And it assigns lower weights to events with low case counts. So we were talking before the show, tralokilimab had the highest PRR. That was the proportional reporting ratio. It had the highest, but there were only 2 cases of CTCL when the tralo patients. So by doing this calculation of the AE score wound up being very, very low for tralo. So that's the one I focused on because they have different charts for RORs and PRRs. The AE score, I think, kind of cleans things up a little bit. I
gotta say for our listeners, Patton just pronounced it tralokilimab.
Tralo.
It is not tralokilimab.
Kilimab.
Tralokinumab. Tralokinumab. Not Kilimab. They don't want to call it Kilimab.
No. That's a horrible name.
Terrible.
Kill you bad. All right, supplementary figure 1C shows where CTCL falls compared to the other reported conditions in the dupilumab patients. So this was just a chart of the AE score versus condition. And CTCL actually falls in the middle. Like the highest AE was pruritus. Do you think Dupi causes pruritus? I do not. AE for conjunctivitis was high. I think we all think Dupi does cause conjunctivitis. So it's almost like a combination of, yes, maybe true side effects, but maybe also just the patients themselves, not necessarily the drug. You had higher AE scores for sunburn. I don't think that's the result of Dupi. Miliaria, CTCL had an AE score similar to keratoconus, which is, I think, part of atopic derm. Eosinophilic granulomatosis and polyangiitis, which I don't think Dupi causes that, but I think
it does.
I don't know about that. Well, I think those patients are like hyper eosinophil. They're kind of in that
they already
phase. Yeah. And morphologically, maybe they have something that looks like eczema. So supplementary figure 2A through D, they plot AE score versus a chi-square. So a higher chi-square means that the association is less likely by chance. So in these graphs, if you're in the upper right quadrant, that's something that happens disproportionately reported with Dupi and very unlikely to occur by chance alone. So the events that occur in those upper right quadrants are CTCL, but urticaria shows up in that upper right quadrant. So does pruritus. So does conjunctivitis. So it's very tricky, especially with this large database. Like, do we have a true cause and effect? But CTCL does keep showing up. They looked at other drugs and using that same AE score, Dupi had the highest AE score, but ustekinumab, IL-23 inhibitors, IL-17 inhibitors, they all had AE scores that were higher than 2.5, which is what the authors kind of said that's the number where above that it is probably meaningful. Now, so that's the epidemiologic stuff. Do we want to say anything about that before going on to the transcriptome, or do we just go on to the transcriptome?
Dive on into the transcriptome. Let's hear it.
I'll just say I remain unconvinced. The fact that it's listing pruritus as like in the far upper right, just like CTCL. I remain unconvinced.
Yeah. All right. The transcriptome stuff looked at bulk tissue single cell expression, IL-4RA and the IL-13RA1, and keratinocytes and DCs and healthy tissue and AD patients and CTCL. I can't say I totally understood it, to be honest. It was too many things going on. It was like DCs have this and keratinocytes and there's overlap and healthy skin and atopic and CTCL. So I understood it and I was reading it, but as soon as I was done reading it, I could not tell you what the big summary was. The authors summarized it for us, and they say, look, this is how this mechanism happens. Keratinocytes in atopic patients, they act as an IL-13 sink. When you give Dupi to patients, you block the keratinocytes from sucking up the IL-13. There's more IL-13 available in the environment to drive CTCL cells. I mean, it seems to me that Dupi would also bind to the IL-13 receptor on CTCL cells. Yes. I know, Matt. Blocking them from using IL-13. So the authors don't really go into how the CTCL cells somehow overcome this. A nice little picture at the end of the supplementary, just kind of going through their theory and what they think caused it. I don't think Dupi causes CTCL. I think that there are patients who have CTCL incorrectly diagnosed as atopic derm, or maybe what any good dermatologist would say, okay, this could be atopic derm because of the biopsy, this, that, the other. They give them Dupi and it unmasks CTCL. I'm not buying the cause and effect, which means it is probably true. That it is probably true. But I'm not entirely convinced.
And we're going to get into that in depth as we go forward. This article did nothing to convince me. Basically, they said there's lots of IL-13 in the tissue, and somehow it's a magic black box. Somehow that's how it's driving CTCL. Literally did nothing to convince me of anything. But we'll see. When we have Dr. Geller's article coming up, it did convince me that there may be a possibility. But before we go that far, Dr. Ferris, let's jump over to your article. Which really changed something that I've been changed what I've been telling patients since residency. But I'll let you go ahead.
All right. So my article is overall and cause-specific mortality among patients with cutaneous T-cell lymphoma in the United States. Shea et al. This is in the European Journal of Hematology, spelled the wrong way with an AE. Instead of just an E. We just got to point that out. So this was a SEER 18 registry data. So almost 10,000 patients who had mycosis fungoides, Sézary syndrome, primary cutaneous anaplastic large cell lymphoma, subcutaneous panniculitis like T-cell lymphoma. So kind of all the subtypes diagnosed between 2000 and 2018. As you can imagine, the majority of these patients had MF, so about 80% of them did, and only about 3% had Sézary syndrome, so little bits of the other ones. So what were kind of the interesting things here? One was that everybody has an increased risk of mortality. So even patients with early stage MF had increased risk of mortality, a standardized SMR of 1.2. So not like a huge increased risk, but it was there for everybody.
But it's 20%.
20% above normal.
Right, more likely to
above
die.
what you would expect. So that's so it's the ratio basically of observed deaths in the study cohort attributed to that cause versus the expected in a control population. So
this is what changed so when we were residents, I swear that I was taught up, down, and sideways that people with early stage MF had no increased mortality compared to the general population.
We were 100% told that, right? So we were told, oh, this is a disease, but it is a cancer, but your risk of death is not higher. So this would tend to, refute that. So, other important things. So, let's see. we found here. So other malignancies were sort of increased across all of the different subtypes. CTCL was the most common cause of death across all of these groups as well. So
it seemed like there was a ton of Hodgkin's
and then
lymphoma.
a lot of Hodgkin's lymphoma, particularly among the MF group. I think that was the only one that really had that increased risk. So,
Is there? What did you? So
and
Dr.
increased
Geller,
mortality from leukemia too. MF,
okay.
primary cutaneous anaplastic large cell, and subcutaneous panniculitis. But not in Sézary syndrome. The other thing was that the risk of sepsis or infectious death was actually pretty low. I feel like that was something that we were told was a big cause of mortality among these patients, and that was actually not the case. Most deaths from lymphoma, so most deaths in the first year are actually from lymphoma. So that is probably in that first year after diagnosis, the time to monitor them. And not surprisingly, the Sézary cohort had the poorest overall survival. So, what was their kind of take-home message from this is that need for better therapies and then closer follow-up for patients with CTCL, regardless of stage. So basically, we can't just say early stage disease, you don't need to worry about them. Those were my big takeaways from this study.
Yeah, it's a big change for me. I mean, I was with my early stage people. I was like, well, we're going to send you to the CTCL center, but you're going to be fine. Don't worry about it. I'm going to have to kind of change what I'm telling people. And so, Dr. Geller, is the Hodgkin's lymphoma connection, is that like a known, like, I guess I don't, it seems those like they're two different cancers to me, CTCL and Hodgkin's lymphoma. Like, is there a real connection there?
So we do see a lot of patients with comorbidities, and like Hodgkin lymphoma is definitely one of the other hematological conditions we see in patients with mycosis fungoides. And usually it's like this history of Hodgkin lymphoma. There is there are some thoughts that the treatment for the Hodgkin lymphoma might cause some immunomodulation of the T cells, which make it easier for new clones to emerge and develop on the skin. So definitely it's something that is well known, and we do get to see it. Other entities like lymphomatoid papulosis also get to be seen very frequently with other like hematological conditions. So, I mean, I completely agree with what you mentioned. Also, this is what I learned, that this is still what I usually tell my patients. I do tell them that even in the early stage disease, there is a chance of something like 10 to 15% of the disease to progress to a more advanced disease. But overall, the lifespan is going to be the same as the normal population. We discussed that before. I mean, all of these like big data registries, they have a lot of biases. So it depends on what was reported and, what's the diagnostic criteria that was used. And we do see that the early stage, like 1A, 1B, which just have patches and plaques, they have like overall great survival. And specifically nowadays that we have a lot more like offers, like treatment offers to these patients. So,
okay. So
I don't know.
I guess the other take-home point for dermatologists like me, who the minute that they see any sort of cutaneous lymphoma, send it to somebody else, was that actually patients with MF were at increased risk of death from skin cancer. So maybe that means, I should still follow them for their non-CTCL issues. So I thought that was interesting too. I don't know if that's, again, biased.
You got to keep them and do the biopsies and cryo, generate the revenue for UNC, and then send them to somebody else for their CTCL and let them do the 45-minute visits with no procedures.
That's what,
send those to Duke.
Send those to Duke.
No,
right,
but
so,
I thought that was an interesting point, that they die more from skin cancer. So
yeah, at Memorial, we keep these patients again, and sometimes we just explain to them that it's good to be also followed by someone who knows this disease, because sometimes there are like tricky elements there. Some of these patients do start like to rapidly progress, and it's good to have someone so that they can contact and be seen like immediately. So even the 1A patients. Some of them have just like a single patch, the same, always same area, just using clobetasol. I get to see them at least once a year. Unless the patient doesn't want to come, and then he knows that if something flares up, he can always reach back. But we do keep also the early stage, because it is like the small amount of patients who do develop more aggressive disease can really become very sick. So we prefer to keep them close.
All right. Now,
That's funny. I do have a couple of like CTCL patch plaque diagnosed, 15 years ago. And now I do see them for their other skin stuff. Do you ever see that? Do you ever see patients who have like CTCL 15 years initially diagnosed and then it blows up? Or if you get 15 years out from like a patch plaque diagnosis, are you pretty much like, yeah, the CTCL is not going to be a problem in those patients?
Yeah, usually this is the case. Usually if the disease becomes aggressive, it happens in the first or second year. It's rarely to be seen like decades after that. But again, some of the patients, as they get older, the immune system probably becomes weakened, and then, things do change. And again, some of them even from the era of getting this like PUVA treatment, I have several of these patients. So even if it's not directly associated with their disease, it's they do develop like very nasty non-melanoma skin cancers and other things that require them to be under better control because of the adverse effects of the treatments they receive.
Okay. All right. Before we go into your article, one basic CTCL question, just two, and I like literally, if I see CTCL at this point, I just immediately send him to the university. So I haven't thought this through in a long time. Remind me of how staging works. Is it stage 1 is skin limited disease, stage 2 it's in the lymph node, stage 3 it's in your blood, and stage 4 you got tumors? Or like what's the very basic thumbnail sketch of the staging?
Yeah, so it goes based on TNMB. So T is like for the tumor, for the skin compartment, and then you have the nodes compartment, and then you have the B is for the blood compartment, and you have M, which just drives them to the highest level, right? Metastasis, if it's like in the liver, in the bones, in like anywhere that beyond the lymphatic system. And then for us dermatologists, the most important is to understand what's going on the skin. If it's just patches and plaques up to 10% of the body surface area, then the patient has no lymph nodes and no blood, then it's in 1A stage, which is the lowest. 1B, it's if he has patches and plaques which are up to 80%, so between 10 to 80%, meaning he's not retrodermic, so then he's like 1B. If he does develop lymph nodes, that will bump him up to 2A.
Now, what if does just feeling lymph nodes get you to 2A? Because they could be reactive. Does it have to be a biopsy proven?
Yeah, sometimes we try to get to biopsy, but sometimes it's, it's very, you do a PET scan, you see that it's a clear cut, and that will just put them into the 2A. And again, 2A is just based, like you said, on clinical palpation. And if the biopsy does show that there is like involvement, then it will be like a stage 3. But for the skin, if it's tumors or erythroderma, then that will make them into like stage 2B, which is the first part of the advanced stage disease. They have much poorer prognosis. And interestingly, they even have a poor prognosis compared to the stage 4, which is the erythrodermic patients. And within that, the ones who do have like lymph node, that will put them into stage 3 as well. And the ones who have blood involvement, that will put them into the stage 4. So it's an integration of the 3 compartments. So usually when we see, for 1A, you don't need to do all of the staging, but for usually 1B and above, we do send them to PET scan or CAT scan. We do blood work to see if there is like any circulating clone in the blood, which is clonality testing and flow cytometry. And based on that, you can say if the patient is like early stage versus advanced stage. So,
and we can kind of think of it as early stage as skin limited, maybe some reactive lymph nodes. Late stage, it is definitely malignant cells in your lymph nodes, your blood, somewhere.
And tumors or erythroderma. You can have like a patient, if he has even one tumor, that will upstage him. Their prognosis is much worse.
Okay. All right. So
Yeah.
Let's go ahead and get into our Dr. Geller's paper here that, again, just as Dr. Ferris's paper really changed the way that I think about sort of early stage CTCL, and I'm going to be a little less, don't worry about it. So I'm going to kind of give our audience the very brief summary of CTCL and Dupi. So early on, people thought Dupi might be a treatment for CTCL. So the group out of Northwestern treated a number of people with known CTCL, and they got worse. And so then it was, maybe Dupi makes CTCL worse. And then we didn't hear a whole lot about it. We hear case reports for a while. Then about a year and a half, 2 years ago, studies started coming out that were basically like, let's look at a big database and see if people who go on Dupi are more likely to get CTCL. And these were all saying yes. People who went on Dupi were more likely to get CTCL than people with AD who didn't go on Dupi. But all of those were just dumb studies because they didn't control for the severity of disease. So the real fundamental question is, there's some number of people who clinically and histologically, you cannot tell that it is not atopic dermatitis. You look at it, it looks like dermatitis. You biopsy them, comes back dermatitis. Even if you biopsy them and say, I think this might be CTCL, it comes back dermatitis. And you're not gonna find out that it's CTCL for some predefined period of time. And now those are generally people with relatively widespread disease. And so the assumption has been that if you go on Dupi, it means you've got over 10% BSA. Over 10% BSA is probably a risk factor that maybe you've got CTCL that is masquerading as atopic derm. And then when you go on the Dupi, the AD is going to clear up, and now the CTCL is diagnosable. That's been the general idea, and there hasn't been a single study that really, deviated from that pattern at all. And then Dr. Geller published back in the very beginning of 2025 this year, looking at all of their patients at Memorial Sloan Kettering, and essentially it turned out there were 30 cases or maybe 32 cases, I think, of people who got diagnosed with atopic derm, then got treated with a systemic, then got diagnosed with CTCL. And of the 32 cases, every single one of them had been on Dupi. Now, some of them had also been on a JAK. 2 of them had been on a JAK at some point as well, but the other 30, every single one had been on Dupi. Not a single person on Trelo, not a single person on a JAK inhibitor without ever having been on Dupi. And at this point, right, so this went up through 2024 in their clinic, like, we've had JAK inhibitors for several years. We've had Trelo for a number of years. There have been enough people on those drugs now that if this was just, disease, CTCL masquerading as AD, it seems like pretty unlikely that every single case would have been treated with Dupi. And so that is it's the first thing that makes me say, well, maybe this is like not just a class effect of systemic drugs for AD, but something related to Dupi. And I'm going to kind of, that was my interpretation of the study. Let me just read the title of the study here so that if anybody wants to look it up. And we always forget to mention this, but on the Scholars in Medicine platform and on our the sites where the podcast is running, we have slides that go along with this. So the key visuals and tables for most of the articles that we talk about are there. But so it was diagnosis of cutaneous T-cell lymphoma following exposure to biologic agents for atopic derm, a retrospective cohort study from a single tertiary cancer center. First author, I'm sure, was a medical student, last name Liao.
Yeah,
and Dr. Geller, our guest, was senior author. So Dr. Geller, I'm going to kind of open it up to you. It was a great idea. And so I'm assuming you started doing this study thinking, geez, pretty much everybody we've seen who's got this story has been on Dupi. It just, you're a CTCL guy. How do you read this whole situation at this point?
So you mentioned like the FARS database before, and we discussed that also before the broadcast. But when you get all of these large data sets, and then you start asking yourself how accurate are they? Is there how much confounding there is? How much biases are into them? And then you go back to your clinic, which you control very well. You know exactly what the patient has and all their exposures and for how long they've been on all of these drugs. And then I wanted to go back and see if indeed I see this this increased risk that is well described in the case series and case studies, but also in these big data sets. And we ended up doing this. We just took all of the patients that we saw with any biologic therapy, and we tried to understand what are the patterns that we see. So of course you cannot make causality based on that, but there is like some story that you can make out of it. And I think that more than the fact that it's only Dupi that we found that is like an exposure that it is associated in these cases with CTCL, it's also the fact that it's only Dupi for atopic dermatitis. So many people ask me, so Dupi is causing CTCL, and I say immediately no, because if it was causing that, nowadays it's given for a lot of other like etiologies. So I would expect to see patients with CTCL who got it for like eosinophilic esophagitis or for asthma, and we don't see that. And we don't see that in the literature either, and we don't see that also in some of the in the literature that like the paper that was published by Hassan et al. I think you talked about that in the JAD that looked into TriNet X about also like Dupi and CTCL. It was only in atopic dermatitis patients.
Yeah.
So it's something specific about this like triad of atopic dermatitis, dupilumab, and I would say a CTCL that is at the background. I don't think that the Dupi is actually driving atopic dermatitis into CTCL, although there is a lot of epidemiological studies showing that patients with atopic derm, they have much increased risk of developing cutaneous lymphoma based on like the long-term like antigenic exposure and antigenic.
So I'm going to do one of my normal interruptions here. So when we were residents, we were taught that the majority of cases is CTCL. I don't know if I'd say the majority, but often it was chronic dermatitis, chronic stimulation of your lymphocytes. And I think I mentioned to you in an email that maybe that I almost have thought of it the same way you think of a Marjolin's ulcer, where like if you got a chronic wound and you're constantly, your keratinocytes are turning over, trying to heal, that eventually one of them mitoses one time too many, and is that a general stepping away from the dupilumab or Dupixent aspect to this? Like, how do people think of chronic dermatitis as driving CTCL at this point?
So yeah, it's still the same ideas are still exist. I would just say that there are some ideas in recent years also about the microbiome effect on that, but that also works the same way. Just that this chronic like staph infection and chronic infection, skin infection in general, they're just also serving as a supra-antigen, causing this chronic like chronic like inflammatory process that is keep the T cells and the lymphocytes secreting these cytokines and having these high profile inflammatory conditions that eventually causes the emergence of this like monoclonal population that is getting out of control and populates the skin, and you end up with a lymphoma. But you see that also not with cutaneous lymphoma. You see that also with non-Hodgkin lymphoma that it other than skin lymphoma, because some of the studies, the epidemiological studies, they try to rule out these cases of cutaneous T-cell lymphoma just because it's so hard sometimes to differentiate. Because even if you do clonality tests, we know that some of the atopic dermatitis, you have these entities of like clonal dermatitis. You end up with a clone that is like dominant in a inflammatory or reactive process. So it's very complicated. So some of the studies just looked into lymphomas without the CTCL component. But we have like several studies done both in the US and also international showing that there is an increase in these cases. And nowadays the thoughts are that these are probably patients, either it's like clearly like misdiagnosis, but not necessarily these are all the cases, right? Because eventually we do see, and for example, in this study that we are discussing now, about 70% of the patients who received Dupi were patients who had like a biopsy before they received the Dupi. So the outside dermatologist did great, and they wanted to confirm the diagnosis before starting biologic, and ended up with a result showing atopic dermatitis. And some of these biopsies also were reviewed by our pathologist, and they agreed it was atopic dermatitis.
So has
So there are
anybody
two
looked
options.
at any of those cases to see if there was a clonal T cell population prior to starting this? Like, I mean, could there be that there's, this antigenic stimulation, you start to develop a clonal T cell population that's not malignant, and then you shift sort of the tumor microenvironment by putting in, Dupi, and now that we know that Th2 responses are maybe important in protection against some kinds of skin cancer, and then you shift that tumor microenvironment, and now that clone can transform. Like, so was the clone ever there before the Dupi, and then did it just go bad?
These are one of the studies we are ongoing, and we definitely look into that. I mean, for us, we need to get the material from outside. This is the difficulty in dealing with such a rare disease, because you need to get like the blocks, and to hope that there is still some activity that will show up in the TCR.
Yeah, I saw in your study that you guys, of the 20-some biopsies, you guys were able to get 5 of them to review, and I'm sure you had medical students like calling the path labs, going to the path labs, knocking on the... Yeah, it's hard to get the outside block a lot of the time.
So since we have thousands of dermatology listeners on our podcast, if anybody has a case of a patient who was developed CTCL on Dupi, should they reach out to you if they have the biopsy pre-treatment? Yeah. Maybe we'll feed research here on Derms on Drugs.
Well, so is it? I also have a memory that the etiology of CTCL, the mutation is like in either the T cell receptor or in one of the co-stimulatory pathways that basically just locks that T cell in a activated proliferative state, rather than like the normal oncogenes and that kind of stuff that you see in normal cancer. Is that, am I?
You're remembering super antigens.
Super, right? So, right, it's turned on like a super antigen.
Yeah. So definitely some of the mutations are in the TCR, like in the T cell receptor, but the more we get data on the genomics of T cell lymphomas, we just get to see how complicated it is. And some of the cases we don't see any of these mutations in a T cell receptor. Some of them we see in like known pathways that would definitely are targetable. One of them is, for example, the JAK-STAT, and because of that, there are some thoughts about using JAK inhibitors as treatments. And we had a trial looking into use of ruxolitinib as an oral medication for patients with CTCL, and we had like a subpopulation with JAK fusions and JAK mutations that received it with mixed responses. So yeah, I mean, the genomic aspects of CTCL are much more complicated than I think we hoped when we started looking into that, and so far there is no specific findings that get to a conclusive decision about how these cases, probably also what we considered as CTCL and even mycosis fungoides, is based on the lumping together different entities. So with the more data we get and more samples we get, hopefully we can start to do more patient-targeted therapies and diagnosis, and also prognosis will be different. So genomics, like it's a big thing, but yeah, I think that eventually when we look into when both into our paper and the previous papers we discussed, these cases are extremely rare. So probably you can look into that as like a two-hit theory. So these are patients who are thought to have atopic dermatitis or truly had atopic dermatitis. they had like probably a malignant clone that was either dormant or well controlled by the reactive process. And then once you treat them with Dupi at this specific constellation, the eczema resolves, and the patients, and there are reports about patients who developed CTCL that initially had good response to the Dupi, and then after a few months they started to flare up. So probably it's like you treat the reactive process and then you unmask the underlying CTCL. This is what probably is going on. And because of that, getting back to, to the big questions, should we avoid Dupi in some cases? I think we shouldn't. I mean, the numbers are very small, right?
Well, wait. Let me ask that a slightly different way.
Yeah.
Let's take a patient with no good reason to choose, say, Dupi over Trelo. Right, so they don't have any atopic comorbidities, they don't have asthma, they don't have allergies, they don't have eosinophilic esophagitis, they don't have COPD. I know, like, it's really a toss-up. And I know I'm asking for speculation here, which as a actual scientist, right, you hate speculation, but I'm specifically asking for speculation. Do you think this is a unique effect to Dupi? So if it really came down to it, and you said, do you think that this is going to be, eventually we're going to see it with all of our atopic derm drugs, or do you think it is a unique Dupi thing that would be a tiny little thing, not rarely if ever a defining factor for choosing therapy, but a tiny little thing on the scale away from Dupi towards other therapies?
I mean, if both treatments are accessible to the patient, so I think it's, of course, like trying the Tralo makes more sense. Although, again, we don't have any literature or large literature on Tralo. It's like really anecdotal. So I can show you like a different example. I have a patient who has like a clear-cut atopic dermatitis since he was a teenager. And he was in the process of getting a biologic, and they thought, about Dupi or something different. But someone did a biopsy, and a report came back saying that he has a T-cell dyscrasia, which I don't quite understand.
Right.
It's something that doesn't meet the criteria for CTCL. But so from that point, he had another like 5 or 6 biopsies before he saw me. Nobody had the
guts.
Wanted to take the guts. Yeah, it had the guts to start him on any biologic therapy, and the guy was miserable. When you know that he just need Dupi, and he had like 5 biopsies showing nothing. So of course, like if Tralo is available to him, it makes sense. I would say even like you can try JAK inhibitor if that's fine. But the issue is that many dermatologists, they just see CTCL and they are worried about biologics. For anti-TNF also, there was a lot of shaming of anti-TNF as a big no-no in CTCL. We're not so sure today.
You're giving me a taste of my own medicine. I frequently bring up that we as derms often undertreat people because we're worried about these very rare side effects where I could say, well, there's a 0.1% chance this is going to happen to you, but if I don't treat you, there's a 100% chance you are going to be miserable from your skin disease. And that's, the stress and the sleep impact and the infections and the whatever. Like, those are probably a bigger deal than that 0.1%, chance or 0.01% chance or whatever. So to get to a different question that I'm also fascinated with, because it's been one report that I've seen, 7 cases of these Dupi-induced lymphoid reactions that resolve whenever you stop the Dupi. And I can't decide if I believe in it or not.
I definitely, I see these cases. It's cases that have a rash that looks like MF. It's hard, clinically you cannot tell apart, but it doesn't meet the criteria. I mean, the cells are not atypical. The immunophenotype, usually it's not as clear-cut malignant as is usually seen. Clonality can either be positive or negative, but the difference is once you stop the Dupi, this just goes away. So it's more like a lymphoproliferative or lymphatic adverse effect of the drug. And I just had like a patient like that who actually was treated not for atopic dermatitis, but for other entity. And once he was on a hold from the Dupi, everything just went away. And I told him, if your other, he's getting it from his like primary care physician, I told them, you just need to discuss that with them. If you have other alternatives which are not Dupi, that's great. But if Dupi is the only thing that keeps you from, worsening with other condition that you have, I would just continue with the Dupi and we'll just follow you very closely. But we need to be very careful with these things, because if not to like burn out good medication just because anecdotal side effect.
Right.
Well,
We did a trial looking into the CTCL associated with Dupi, compare them to matched patients with CTCL that had no effect or no exposure to Dupi prior to the CTCL, and we showed that the outcomes were similar. So eventually, it's not that they do worse, although there are some case reports showing like a very explosive disease after Dupi treatment. Yep. But our experience at Memorial is that they respond very well to the treatments we have.
Okay. Well, we're going to cut it off there and move over to our trivia section of the show. Unless, Pat or Fairs, either of you guys have any additional questions for Dr. Geller?
No, trivia it is.
Patton?
All right. Yeah, let's go.
All right. So, Dr. Geller, we got to let Patton finish the question. But as soon as he's done reading the question, you can jump in, just shout out the answer as soon as you got a guess.
Okay, we're sticking with the theme of mycosis fungoides. What agent received approval on March 15th, 1949? That's right, 1949, for the treatment of multiple malignancies, including mycosis fungoides.
Nitrogen mustard.
It was nitrogen mustard.
Woohoo!
So technically, mechlorethamine. It was approved to treat malignancies of lymphoid tissue. Way back then, CTCL did fall under that. They didn't know what they were treating, and it was IV back then. But some of those patients were mycosis fungoides people.
Is mechlorethamine actually nitrogen mustard, or is that a different thing?
No, that's it.
No, that's it.
Okay.
Yeah.
Well, all right. 1-0 Cyrus. This could be my first win.
Yeah, that strong out of the gate. I like it. All right. Albert Cesare described a patient with erythroderma and cancerous cells in the skin and blood. The French term that he used to describe these cells could be translated to what scary sounding English term? So now we call them Cesare cells, but what did he call them?
Scary sounding English term. A cerebriform.
No, that's not terribly scary there, Matt.
Kind of a wimp if that scares you.
He called them monster cells.
Oh, that is kind of scary. All right.
He said it in French.
Monster or something, yeah.
Yes, cellulae monstrose. Monstrous cells, if you want to be technical. But that was what we called them, I guess, before we started calling them Cesare cells, which is kind of cooler, actually.
Wait, what are cerebriform nuclei in again?
Those are them.
What's
That's
that?
them.
Okay. All right.
Cesare cells, yeah.
Okay.
Yeah. All right. Last one. Ontac, that's the brand name. It was approved in 1999 for the treatment of CTCL. It was withdrawn from the market in 2014, but reintroduced to the market as Lymphir in 2024. Lymphir is a fusion protein of interleukin-2 and what toxin?
Diphtheria toxin.
It's diphtheria.
Yes, no. Got it.
That's a tie.
I got a tie.
I know Shamir knew that. That's why I had to yell it out really quick.
Yeah, I wanted to see how well you know your CTCL.
It was too easy. It was all CTCL. This was too easy for him. All right, that's it.
All right. Well, Shamir, thank you for coming on the show. This was great, and I feel like I am caught back up on the world of CTCL. And this was just a lot of fun.
Great fun having like another 3 physicians who are excited about CTCL. That's
it's as rare as Dupi-induced CTCL
every day. Yeah.
Wow. To our listeners, thank you for joining us this week. If you got questions, comments, ideas for topics we should cover on the show, shoot us an email at questions@dermsondrugs.com. If you got any of those cases of CTCL following Dupy, don't hesitate to shoot me an email and I can connect you up, or shoot us an email. We can connect you up with Dr. Geller. And whether that goes anywhere or not, who knows? But it's an interesting area. I hope you learned a few things this week. I hope you laughed once or twice. And most of all, I hope you're planning to join us next week. And until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.